Hello dear students. Today we are going to deal with various endocrinological problems in children. Endocrinology as it is known as graveyard of the students because it has got various feedback mechanisms and various enzymatic pathways. And many of the time students don't feel comfortable even after reading thoroughly. They don't feel confident and comfortable enough to answer these questions. So what we are going to do in this today's session is we are going to have a bird's eye view about the endocrinal disorders in children, and I will at the end give you some tips how to remember various disorders and certain key points in each disorder. In today's part, we are going to cover various disorders of sexual development, congenital adrenal hyperplasia, diabetes insipidus, Cushing syndrome, and at the end, a brief idea about growth hormone deficiency. Ambiguous genitalia. Ambiguous genitalia is a spectrum of disorders where the child can present at birth with either bilateral undescended testes, unilateral undescended testes with hypospadias, severe degree of pinoscrotal hypospadias with maybe bifid scrotum, fused labioscrotal folds in apparent female genitalia, and maybe with isolated clitoromegaly. The differentiation of external and internal genitalia into male or female depends on various factors. In utero, when the fetus is growing, up to 8 weeks, the gonads and the external genitalia are identical. At 8 weeks, there are certain factors which are playing role which help the gonad differentiate into either male or female. The various factors are, for example, presence of Y chromosome and the SRY gene on the Y chromosome, presence or secretion of the anti-Mullerian substance which inhibits the Mullerian ducts and thereby prevents female internal genitalia being developed, and also testosterone which favors the virilization and leads to external genitalia more male-like. Any problem or any defect in this process would give rise to ambiguous genitalia. Various causes of ambiguous genitalia are firstly problems in the gonadal differentiation, problems where the female is getting virilized such as adrenal excessive androgen production in cases of 21 hydroxylase deficiency and 11 hydroxylase deficiency, or if the fetus is getting exposed in utero to androgens such as exogenous drugs or maternal androgen secreting tumors. A male can present with under-virilization at birth if he is suffering from adrenal hyperplasia like 17 hydroxylase deficiency, 3-beta HSD deficiency, or if there is a problem in the testosterone production like 17-beta HSD enzyme deficiency or 5-alpha reductase deficiency, or if the testosterone is getting produced but it is not acting on the target organs, which is also called as androgen insensitivity. Congenital adrenal hyperplasia, it is a very high yield topic for any competitive exam because many of the MCQs or the multiple choice questions are being asked on this particular topic. So, if there is a blockage in the pathway of this steroidogenic enzymes which are being produced in the adrenal cortex, if there is a blockage, there is a buildup of the precursor hormones and there is a deficiency of the final product. So this deficiency of the final product, which is in the form of cortisol or mineral corticoids, gives rise to a positive feedback and there is an increase in ACTH hormone. This ACTH hormone further aggravates the blockage and hence there is a buildup of precursors. The adrenal cortex is divided into 3 zones, which is zona glomerulosa, which give rise to mineralocorticoids like aldosterone, zona fasciculata, which give rise to cortisol, and zona reticularis, which gives rise to sex steroids, that is testosterone. Let me remind you that the estrogen that is developed in the females or the estrogen that is derived is primarily by further aromatization of this testosterone. The figure that is seen on your screen is the steroidogenetic pathway. On the left hand upper corner you can see pregnenolone, which is the precursor derived from cholesterol. So all these steroid hormones are derived from cholesterol and it undergoes series of enzymatic processes to yield the final products, which are aldosterone, which is a mineralocorticoid, cortisol, which is a glucocorticoid, and testosterone. I want you guys to pay a couple of minutes on this slide, and whenever we are going to talk about any congenital adrenal hyperplasia disorder, please come back to this slide and see the pertaining hormone where the block is present. 21 hydroxylase deficiency, it is the most common congenital adrenal hyperplasia. It has got two varieties, the classical variety and non-classical variety. The classical variety presents at birth or soon after birth with virilization plus minus salt wasting. So if it presents with salt wasting, it is called a salt wasting CAH. If it presents at birth with only ambiguous genitalia, that is called a simple virilizing CAH. And there are certain varieties of non-classical CAH which present in adolescent females with virilization. 21 hydroxylase deficiency. So as you can see in the figure, we have an enzymatic block present at the 21 hydroxylase enzyme. So the products aldosterone and cortisol are not being produced, and the precursors, those are progesterone and 17-hydroxyprogesterone, are getting accumulated, and these are shunted towards the testosterone pathway, giving rise to excess testosterone. So in 21 hydroxylase deficiency, we have deficiency of mineralocorticoids and glucocorticoids and excessive testosterone formation. So a female with 21 hydroxylase will be virilized, but a male will not have ambiguity because there is excessive testosterone. Both sexes can present with salt wasting. And salt wasting, how does it present? It presents with dehydration, shock, hyperkalemia, hyponatremia. Cortisol deficiency presents with failure to thrive, vomiting, and excessive pigmentation, which is because of ACTH. And the testosterone excess in females gives rise to virilization such as clitoromegaly and fusion of the labial folds. Management of 21 hydroxylase deficiency. If the child comes very early with salt wasting, we are going to correct the dehydration. We are going to supplement him with extra salt. We are going to replenish the mineralocorticoids with fludrocortisone. The glucocorticoid deficiency will be replaced with hydrocortisone. Remember, in pediatric age group, we are worried about the growth of the child, and dexamethasone and prednisolone are two steroids which hamper the bone growth. So for replacement of these steroids, we prefer hydrocortisone over these drugs. If the child is going to undergo any surgery or any corrective surgery for the ambiguity, or if there is any stress in the form of sepsis or any infection, he is going to need increased doses or excessive doses of steroid, which is called as stress dosing. Other forms of CAH are 11 beta hydroxylase deficiency. Please go back to the figure and see where is the block, and you would realize that the precursor deoxycorticosterone is accumulated, which is a strong mineralocorticoid. So even if aldosterone is not getting produced, here we have features of aldosterone excess in the form of hypertension, hypokalemia, and here we have deficient cortisol production, so we have excessive pigmentation. However, these children do not develop salt wasting, but they are hypertensive. In a female, we have excessive testosterone production giving rise to virilization, but the males will not have any ambiguity. In 17-hydroxylase deficiency, there is accumulation of the precursor corticosterone, which is a mild glucocorticoid and a mild mineralocorticoid. So these children also do not develop salt wasting, but they have hyperpigmentation because of raised ACTH. Here, since the testosterone is not produced, males will be under-virilized and females will have normal genitalia. 3-beta HSD is a rare variety of CAH, and these children present with deficiency of all the three hormones, that is glucocorticoid, mineralocorticoid and testosterone. But the caveat here is there is a weak androgen being produced, which is called as DHEA. It gives rise to mild virilization in females. So we have gone through the 4 varieties of CAH, and I'm sure by this time you must be totally confused. So I'll give you some tips how to remember all these conditions. So please look at the screens. A virilized female, so a female that is looking like a male So remember, 1 is like a male. So 21 hydroxylase and 11 hydroxylase are the conditions which look like a male. If we have undervirilized male which looks like a female, so remember 0 is for female, so remember 17 and 3, so the add up 7 plus 3 is 0, so 0 is like a female. So if it is a female looking ambiguous genitalia, possibilities are 17 hydroxylase deficiency and 3 beta HSG deficiency. If the child has ambiguous genitalia with hypertension, remember 11 and 17. So how to remember? Pubertal children are hyper. So 11 and 17 we can remember like during puberty. So 11 beta hydroxylase and 17 hydroxylase come with hypertension, and the remaining, that is 3 and 21, 3 beta HSG and 21 hydroxylase deficiency, can present with salt wasting. Moving ahead, undervirilized male who has problems in the testosterone development but not a CAH. So there are two conditions. Firstly, 5-alpha reductase deficiency, where there is a problem in conversion of testosterone to dihydrotestosterone. Dihydrotestosterone is the active and most potent form of testosterone which gives rise to male external genitalia development. So if we have a block at 5-alpha reductase, the testosterone will not get converted to dihydrotestosterone and we will get undervirilized male. So the features of undervirilization will be a micropenis, severe degree of hypospadias, a bifid scrotum and undescended testes. Usually these children at puberty develop penile growth spontaneously. So this is called as penis at 12 syndrome. So this is a multiple choice question repeatedly asked. And another condition where there is no problem in testosterone production, but there is a problem in the testosterone action on the receptor. So if the receptors are resistant to androgen action, we can get either complete or partial insensitivity. In a patient with complete androgen insensitivity, the testosterone is not acting on the receptor and phenotype is completely female. So though the genotype is XY, the phenotype will be of a female. If the resistance is partial, then we can get a spectrum of ambiguity, and usually these patients have testes in their inguinal canal. These are tall females presenting with inguinal masses, and if we do the serum testosterone levels, they will be high. Undescended testes is a common problem. 30% of the preterms and 3% of full-term babies have bilateral or unilateral undescended testes. Many of these children have spontaneous descent of their testes, and by the age of 1 year, only 1% of children have undescended testes. Various factors favoring the descent are abdominal pressure, the gubernaculum testis which guides the testes into the scrotum, and there are some local hormones like insulin-like protein 3. So remember, a bilaterally undescended testes can be a female actually. So if there is a multiple choice question like a male looking child comes with hyperpigmentation, shock and bilaterally undescended testes, and if the 17-hydroxyprogesterone levels are high, what is the expected karyotype? So remember, this is a classical presentation of salt wasting 21-hydroxylase CAH, and since the testes are not present bilaterally, probably it's a female that is severely virilized. So we are supposed to mark karyotype XX and not XY. Spontaneous descent of the undescended testes can happen up to 1 year. Medical treatment with beta HCG injections is worthwhile, but if the testes fail to descend by 1 year, ideally the child should undergo surgical orchidopexy. And what happens if the testes are retained in the abdomen? Because of the higher intra-abdominal pressure, the sperm count goes down, so there is a future risk of infertility, and there is also increased risk of gonadoblastoma and other embryonal cell tumors if the testes are retained in the abdomen. So by the end of 1 year, if they fail to descend, they should be brought down by the surgery. Coming to Cushing syndrome, the adrenal cortex is under the control of ACTH hormone, which is an anterior pituitary hormone. Both ACTH and cortisol are highest in the morning in the blood, and the levels fall in the midnight. The ACTH is under the negative feedback of cortisol, and it is also suppressed by external steroids. The cortisol is increased during the periods of stress and infection. So Cushing syndrome is the manifestation of excessive glucocorticoid in the body, maybe derived internally or exogenously. Cushing syndrome is The most common cause is exogenous Cushing syndrome, where there is steroid intake. Cushing's disease is the pituitary hypersecretion of ACTH hormone, and ectopic ACTH, though it's rare in children, can be found in various tumors of lungs and soft tissues. The clinical features of Cushing syndrome: if the child presents below 10 years, it is likely that he is having either exogenous or a Cushing's syndrome due to adrenal pathology. And if the child comes beyond 10 years of age, it is likely that he is having central, that is Cushing's disease. Various manifestations are obesity, moon facies, buffalo hump, proximal muscle weakness, striae over the abdomen, hypertension, metabolic derangements like diabetes, and sometimes they can also have irregular menses. And if the Cushing syndrome is ACTH dependent, we can have hyperpigmentation of the gums, mucosa, and the scars. There are many questions being asked on the investigations of Cushing syndrome. So the first sign of Cushing syndrome is the loss of diurnal variation of the serum cortisol levels. So the variability, high in the morning, low in the evening, this variability is lost. If the morning time cortisol is suppressed, that means there is exogenous Cushing's and the child is receiving steroids from the outside. The dexamethasone suppression test confirms the Cushing syndrome, and there is another test called as urinary free cortisol, which is confirmatory for Cushing syndrome. CNS imaging or ACTH levels are the pointers towards the central disease. Diabetes insipidus. Diabetes insipidus is a condition where a child presents to you with polyuria, polydipsia, and there is inability of the kidneys to resorb the water through the renal tubules due to deficiency of either vasopressin or problem in the vasopressin action. So hypothalamus secretes vasopressin in response to increased blood osmolality. The posterior pituitary stores this vasopressin and releases on demand. And renal collecting tubules, which have V2 receptors, they are under control of vasopressin and they control the resorption of water through the aquaporine channels. So diabetes insipidus is either central or nephrogenic. In central diabetes insipidus, we have problems in the formation and secretion of the vasopressin hormone. The underlying mechanisms are head injury, craniopharyngioma, histiocytosis, or pituitary surgery. In nephrogenic diabetes insipidus, we have the congenital variety, which is X-linked, and various drugs like lithium, amphotericin B, and rifampicin can give rise to diabetes insipidus. Investigations reveal, in a case of diabetes insipidus, if the serum osmolality is above 300 and the urine osmolality is below 300, this is the diagnosis of diabetes insipidus. However, if there are borderline cases, we perform a dehydration testing. In dehydration testing, we curtail the fluid intake and allow dehydration up to 5% of the total body weight. And at this time, we measure the serum osmolality. When it goes above 300, we have a diagnosis of diabetes insipidus. After we achieve this dehydration, we give vasopressin. If there is a response to vasopressin in the form of serial concentration of the urine, that gives us a clue about central diabetes. And if there is no response to vasopressin, that gives us a diagnosis of nephrogenic diabetes. In a patient of any CNS injury or a central nervous system surgery, there is a typical triphasic or a triple response. During the first phase, there is a transient diabetes insipidus. During the second phase, which is after 48 hours, there may be a phase of hyponatremia, oliguria, and this is because of the release of vasopressin. And the third phase is permanent diabetes insipidus, which occurs beyond 7 days of the insult. Coming to the last topic of today's session, short stature and growth hormone deficiency. A child is said to be short if the height is shorter than 2 standard deviations for his age and sex, and also if he is short for his mid-parental height. So how to calculate the mid-parental height? For boys, we add mother's height and father's height. We add 13 centimeters to this because that is the difference between an average male and female height, and we take an average of this total. So this is the mid-parental height for boys. For girls, instead of adding 13, we subtract 13, and mid-parental height gives us an idea about the genetic potential of a child to grow. Various systemic and endocrinological causes give rise to short stature. The endocrinal causes are mainly hypothyroid, growth hormone deficiency, pseudo-hypoparathyroid, and sometimes Cushing syndrome. Growth hormone deficiency. Growth hormone deficiency can be either congenital or acquired. A newborn can present with hypoglycemia, prolonged jaundice, and micropenis. Remember, a growth hormone deficient child doesn't present with short stature in newborn period because the length at birth depends on the maternal nutrition and not the growth hormone. So they are of a normal length at birth, and as they start growing, the fall in the growth velocity is apparent. So in childhood, we can get proportionate short stature, falling in the growth velocity, doll-like facies, obesity, and there is a characteristic high-pitched voice. Lab diagnosis of growth hormone deficiency: a random sampling or a basal growth hormone level doesn't give us any clue. So we have to perform dynamic testing in form of growth hormone stimulation testing. Various stimuli that are used for this testing are glucagon, insulin, dopamine, clonidine, and arginine. So there can be a multiple choice question framed on these stimulation tests. And the bone age, if we perform in these cases, it is usually delayed. Growth hormone deficiency can manifest as isolated deficiency, or sometimes it can present with hypopituitarism, where we have deficiency of other pituitary hormones like ACTH, TSH, LH, and FSH. So before starting the child on growth hormone, we have to make it certain that we have ruled out hypothyroid and we have ruled out ACTH deficiency, and if it is present, we have to replace or we have to replenish the child with cortisol and thyroid hormone first before starting the growth hormone. So with this, we conclude today's session of endocrine disorders. Thank you and happy studying.